Cardiovascular disease accounts for nearly 20 million deaths every year. Yet for decades, the standard medical approach to prevention has been a waiting game. The traditional model relies on letting patients reach their 40s or 50s before screening for risk. When doctors do screen, they typically run a standard lipid panel, measuring LDL-C. This test calculates the total mass of cholesterol in the bloodstream. If that mass hits a certain threshold, or if the patient already shows signs of disease, they are prescribed medication. The system reacts only after the danger has declared itself. This diagram illustrates the problem with relying on LDL-C. On one side, we have a few large cholesterol-heavy particles. On the other, dozens of small, cholesterol-depleted ones. The total mass is exactly the same, but the number of vehicles carrying that cargo is completely different. LDL-C only weighs the cargo. It ignores the traffic. To count the actual traffic, we have to look at Apolipoprotein B, or ApoB. Every single atherogenic particle, the ones that cause plaque, carries exactly one ApoB molecule on its surface. Testing for ApoB provides a precise, one-to-one count of every dangerous particle circulating in the blood. When the particles are small and dense, a patient can have a low cholesterol mass, but a dangerously high particle count. By measuring the cargo instead of the vehicles, the traditional model underestimates the physical threat to the arterial wall, leaving patients unknowingly exposed for decades until they suffer an event. The danger of a high particle count becomes obvious when we zoom in on the endothelial wall, the inner lining of your blood vessels. Heart disease doesn't start as a vague systemic condition. It is a highly specific mechanical failure. Under the currently accepted response to retention framework, the disease initiates when circulating ApoB particles breach the endothelial barrier. Once inside the subendothelial space, the positively charged ApoB molecule ionically binds to negatively charged structures in the arterial wall. The particle is physically trapped. Cut off from the circulation, the trapped particle degrades. It oxidizes, aggregates, and triggers a chronic, localized alarm. The body responds by dispatching immune cells called macrophages to consume the debris. But the macrophages gorge themselves without restraint, dying and accumulating into a lipid-laden foam that builds the plaque. The resulting inflammation is not the root cause. It is an entirely downstream reaction. Without the non-redundant first step of the ApoB particle getting physically wedged into the arterial tissue, the downstream inflammatory cascade that causes atherosclerosis simply does not happen. Because plaque builds physically over time, clinical progression is a math problem. This chart shows an individual's lifetime exposure, plotting circulating particle concentration against decades of life. We call the accumulating area under this curve ApoB years. The injury to the artery is the direct product of how many particles you have multiplied by how long you've had them. The disease progresses silently until it crosses a critical cumulative threshold. Epidemiological models indicate that the incidence of clinical heart events begins to sharply accelerate once a patient accumulates roughly 5,000 mg per deciliter years of exposure. For someone with average lipid levels, that mathematical tipping point arrives right around age 40. Curious. This graph compares two very different sets of data. On the left, standard 5-year clinical trials show that lowering cholesterol later in life reduces cardiovascular risk by about 22%. But on the right, Mendelian randomization studies, which look at people genetically predisposed to maintain low lipid levels from birth, show a massive 55% reduction in risk. This gap between short-term trials and genetic data is not a paradox. It is the signature of a cumulative disease. Starting therapy in your 50s merely stabilizes the dangerous rupture-prone lesions that have already formed. Maintaining low ApoB from childhood prevents those lesions from ever existing. The logical consequence of this math is that intensity is less important than timing. The most effective way to prevent cardiovascular disease is to lower ApoB early enough in life to ensure the patient never accumulates enough exposure to cross the clinical threshold. Implementing this lifespan strategy requires entirely new clinical timelines. Pediatric guidelines now recommend universal lipid screening between the ages of 9 and 11. The goal is to identify children with familial hypercholesterolemia, a genetic condition that causes extremely high ApoB, before puberty, allowing them to manage their trajectory before the damage accumulates. For low-risk populations, the first line of defense is primordial prevention through lifestyle. Adopting a Mediterranean dietary pattern, lowering saturated fat, and consuming daily plant sterols and viscous fiber directly upregulates hepatic LDL receptors, pulling ApoB particles out of the blood. but lifestyle modifications have their limits. For patients with a genetic burden, established subclinical plaque, or rapidly accumulating ApoB years, dietary interventions are mathematically insufficient to bring their particle count down to a safe baseline. Pharmacological therapy becomes necessary. The most common barrier to sustained drug therapy is the widespread fear of statins. Specifically, patients frequently report muscle aches and stiffness, leading them to abandon the medication and resume accumulating arterial damage. This bar chart visualizes the results of the SAMSON crossover trial, which tested patients who had previously quit statins due to side effects. The data reveals that 90% of the reported symptom burden was reproduced by a placebo. The vast majority of muscle pain was driven by the nocebo effect, the expectation of harm, rather than the drug's actual pharmacology. For the small fraction of patients who do experience genuine pharmacological intolerance, modern lipid lowering is highly customizable. Physicians can utilize hydrophilic statins that bypass muscle tissue entirely. They can add ezetimibe to block cholesterol absorption in the intestine, or deploy PCSK9 inhibitors to rapidly clear particles from the plasma without the side effects of traditional statins. The science provides a clear mechanical target and the tools to dismantle it. By abandoning the reactive question of whether a patient is high risk today, and instead aggressively managing cumulative ApoB exposure from youth, we possess the capability to engineer atherosclerotic cardiovascular disease out of the human lifespan.